My name is Naresh Gunaratnam, and I am affiliated with St. Joseph Mercy Hospital in Ann Arbor, Michigan, and I'm Director of Research for Huron Gastroenterology. I'm also senior author of a paper entitled The Efficacy and Safety of the Band and Slough Technique for the Treatment of Non-Ampullary Duodenal Adenomas. This technique was discovered by accident. I had done a duodenal adenoma resection in an individual approximately 4 years ago. She developed significant pain after the procedure and developed a transmural injury in the second portion of the duodenum, necessitating CT scans and swallowing studies to rule out perforation. She had significant pain for about a month, and I think I lost 2 months of my life worrying about her. The next time I had a patient with a duodenal adenoma, I think I suffered from post-traumatic stress, and right before I was going to use hot cautery to remove this polyp, I elected not to use hot cautery and just left a band on the polyp, which was approximately 1 centimeter. The patient was then brought back in 2 months to reassess to see if the polyp was there, and to my surprise, the polyp was gone. So this is how this technique started. We subsequently used this on 9 other patients over 3 years and found it to be quite effective. 80% of the patients had sporadic adenomas and 2 patients had familial adenomatous polyposis. We found this to be quite effective in removing the polyps. In 50% of the patients, 1 session was sufficient to remove the polyp completely, and the rest, approximately 2 other procedures where we used argon plasma coagulation and or repeat banding to remove the polyps. We have up to 24-month follow-up, and when we have demonstrated complete eradication, we have shown that it has not recurred. I found the technique pretty straightforward. I passed the variceal band ligator into the duodenum. The hardest part is getting it through the pylorus. Once it's through the pylorus, we identify the duodenal adenomas, and we suck it into a chamber as we would Varix. And typically I deploy 1 band. If it's a larger polyp, I'll put on 2 to 3 bands such that the whole polyp is ligated such that there's no base. We then don't use any cautery. We typically reassess the patient in 2 to 3 months, and then if there's any residual polyp, if it's small, we'll treat it with argon plasma coagulation, and if there's any larger polyp, we'll then reband that area and again leave it to slough. The mechanism of polypectomy is ischemia and necrosis. Our injury level is believed to be to the submucosal level. We don't get transmural injury, and as a consequence, we've really not had any complications of bleeding, perforation, or pain. For the last 3 years, I've done over 15 of these, and I've been able to sleep well, and I think this is a technique that's worth exploring further. I think anybody who is competent in variceal band ligation or endoscopic mucosal resection should be able to do this quite easily. I would start with polyps less than 1 centimeter. Those are the ones that we have the best luck with. And those that are larger, you have to be careful about. Make sure you have the histology demonstrating that you don't have advanced dysplasia, high-grade dysplasia, or obviously intramucosal cancer. This would not be a technique that I would use for more advanced dysplasia. So if you choose to do this procedure, good luck. And I would love to hear your feedback about how this procedure works for you, and I believe this is a promising technique for small non-ampullary duodenal adenomas. So good luck.